Usually patient will present with quadriparesis
Are
sometimes.
they conscious or unconscious?
Can be unconscious coma stage.
Are they febrile or non-febrile?
Febrile,
So this is not
not
here. But
more
least,
than
least
50
common
percent.
site.
Yes, sir.
Next
Uh,
fifth least common site is subcortical.
Subcortical.
So first possibility is that cerebrovascular accident bleed. The five sites
Yes, sir.
does not have classical features. Now the question is, do they come abruptly or insidiously?
Usually comes abruptly.
Is this patient coming abruptly?
No, sir. Over 2 days.
2 days.
So,
So what's the next
yes, sir.
option you have got?
Next option is patient is hypertensive. Maybe she's on some treatment which has caused uh, hyponatremia. Hypertensive, antihypertensive might have caused
So you think it
hyponatremia.
is a medication induced problems, metabolic problem.
Yes, sir.
Yes. What is the
Yes.
other differential diagnosis you have? Can this be cortical venous thrombosis?
Yes.
Yes or no?
Yes, sir. It can be.
It can be. What other symptoms you get on those patients?
Patient will present with seizures.
Seizures and altered sensorium. This
Also
patient is not
sensory.
having altered sensorium, no seizures also. Yes. Yeah, any other possibility? Can this be meningitis?
Here there is no history of fever.
Fever may not be present in case of elderly people and immunocompromised. So fever is not there. Okay. Then can this be encephalitis?
No,
It cannot be.
as per history also.
Can this be cerebral malaria?
Again, there is no history of fever,
Okay.
seizures.
What about brain abscess?
Brain abscess also presents with fever.
Fever will be very mild in case of
Very
brain
well.
fever unless the just gets spread to the meninges producing meningitis. So high fever is not a feature of brain abscess commonly. So you put two possibilities here. Cerebrovascular accident is one, that is bleeding, and then second possibility you said is metabolic problem, hyponatremia. So the first sentence is over. Go ahead. Go ahead.
Family
No,
history,
the
there is
patient is
nothing.
not able to walk. Am I right?
Walk since 2 weeks.
Why is it so? What do you think about it? Which are the
One is
yes, one is what are the possibilities?
again hypertensive bleed itself can be a cause.
That can produce only unilateral, no?
Unilateral, yes. Not atypical.
Patient is moving all four
As per
limbs or not?
directive, because of
Is the patient moving limbs?
is moving forward. Yes.
So it's not paralyzed, but the patient is walking. Why is it so?
Maybe ataxia.
But when you read further, there is no ataxia, no?
No ataxia.
Okay. So why is this patient not able to move? So we will go to take a deviation here. What are the atypical things in elderly people as far as symptoms are concerned? How do they differ from young people? If a young man gets myocardial infarction, elderly gets myocardial infarction, what is the difference in their presentation? Somebody gets a UTI, what is the difference in the presentation elderly and the others? Okay.
Patient might present with
So tell me about
the bleeding.
geriatric giants. What are geriatric giants? Geriatric giants are symptoms with
Patient might
which
present with frequent false
geriatric
positive.
patients present irrespective of etiology and pathology. So the common geriatric giants are immobility. So a patient with myocardial infarction only complaint may be not able to get up in the morning. Same with the CVA, same with the fever, same with the typhoid, same with the pneumonia, UTI, diabetic ketoacidosis, everything the same complaint, immobility. So this patient is old, it's got immobility. Second is they fall because of instability. Again, the letter starting letter I, instability. Then you find them, they pass urine just like that, they become incontinent. Then
Yes.
they become impaired intellect. So four I's come one by one,
Yes.
and of late, few more are added: frailty, sarcopenia, anorexia, aging producing cognitive impairment.
Okay, sir.
So, what is sarcopenia by the way?
Uh, Wasting of
Wasting of
muscles.
muscles. So, what are the end result of all these symptoms? Just geriatric giants. So, 4 plus 4, 8 are there. What are the net result of these geriatric symptoms? First of all, you may miss the diagnosis. You may think it's only a disease of his mind. You may think it's only osteoarthritis, why he is immobile. You may think there's a sedation that is creating problem. So they can all could get extra problems maybe the disease of the mind. M mobility, M medication. So after 4I plus 4 extra things coming up now, we got 3 more: mind, mobility, and medication can produce all these things. Net result is these people tend to fall. So what will happen if an elderly person falls? What will happen?
Fracture.
Which part is getting fractured commonly?
Commonly neck of femur.
So what happens next?
Persistent.
He in the hospital. What all things will happen?
Immobility.
He goes in delirium. He gets
Delirium.
DVT. He
DVT.
gets catheterization, UTI,
UTI.
sepsis, bed sore. It goes like that. So
Yes.
ultimately he will be in trouble. So your patient is having 65 years old and not able to walk since 2 days. And onset was insidious. So what are the
Onset.
insidious diseases you know of in medicine? Insidious diseases.
Tumors.
2 days disease. No, tumor will take many ages.
Infections.
Infections, agreed.
Thrombosis can also be
Metabolic problems.
metabolic problems.
Ketoacidosis, hyperostomal coma, hypoglycemia, hyponatremia, hypercalcemia. So all those things are coming in insidiously. So that should be in the possibility in the mind. So this patient is bed bound. Then comes next what? Read.
Family history, there is hypertension in father. Personal history normal. Drug history, she's on telmisartan, thiazide, and amlodipine and atorvastatin.
Okay, what is the hazard of using? Tell me certain in the elderly.
ARBs, one, it can, if in a patient with worsening of creatinine, it can
So
worsen
how
creatinine.
will you recognize this patient is likely to worsen?
If there is a worsening of creatinine by more than 50 percentage from the previous value, you have to stop ARBs or ACE
So
inhibitors.
in you are starting an outpatient. After 48 hours, you will check the creatinine. Clinically, whom do you suspect to have side effect? Whom
Patients
do,
with renal
patients with renal artery bruit.
renal artery stenosis,
It's okay. Renal artery bruit. You should not give this drug. They will go for acute renal shutdown. Okay. Second drug is what?
thiazide,
So what are the hazards of thiazides?
one, it is notorious for producing hyponatremia,
That is true.
hypokalemia also,
Hypokalemia. Yes. Tell me 10 other side effects.
hyperglycemia,
Hyper 3.
hyperuricemia, and
Okay. Gout.
uh,
Okay. 4.
hypercalcemia,
Okay.
hyperuricemia,
Okay.
hyperglycemia, and
5. 5. Increase the lipid level. 6. It produces hemolytic anemia. 7. Agranulocytosis 8. Thrombocytopenia 9. It can produce what else? Photosensitivity reaction. What is the strongest diuretic you know of? Which group is it? Strongest diuretic? Pardon? Strongest no, the strongest diuretic is metolazone. Metolazone, okay. So, which thiazide is allowed to be used for hypertension as per British protocols?
Chlorthalidone is usually used.
Chlorthalidone and one more, indapamide. But this patient has taken hydrochlorothiazide. So it is likely that patient has got the problem because of that. Okay. And what is the other findings? Drug history. Okay.
Patient appears dehydrated.
Hmm. Hmm.
Vomit is present on clothes.
Okay.
Pallor interest, flooding, cyanosis, lymphadenopathy, edema absent. Pulse rate is 90 per minute. BP is 130 by 80 millimeters of mercury. Higher mental functions are normal. Cranial nerve examination normal. Motor system moving all four limbs. Bilateral plantar is extensor. Sensory system.
Cerebellar signs are absent.
Absent, sir.
Okay. Sensory system is normal.
Normal.
Anything else?
No, serious and respiratory
No,
system
no.
also.
Meningeal irritation is absent.
No, everything is normal.
Absent.
No.
So, where do you put the diagnosis here?
Considering the examination findings, only bilateral plantar is extensor.
So, where do you localize this plantar response?
Metabolic encephalopathy.
So, what does plantar response usually indicate to you?
Pyramidal tract involvement.
Pyramidal tract lesion. So, what are the non-pyramidal tract diseases producing upgoing plantar?
One is metabolic encephalopathy.
Okay.
Then vitamin B12 deficiency can cause subacute fungus. That is also due to pyramidal tract involvement.
Okay.
Then post seizures.
Post seizure, very good.
Then shunt encephalopathy in CLD.
Hypoglycemia, yes. Hepatic encephalopathy, right? Yes.
Sleep coma stages and all.
Deep sleep and coma of any nature, yes. Metabolic problems. Yeah, so you had wide varieties of situations. So in pyramidal system, where do you localize upgoing plantar?
Bilateral pyramidal tract involvement.
Where is the level? Where is the level? Above? Above? Above?
L5.
Above L5. Below?
Below M.
Upper limit can be where? Upper limit?
Pyramidal.
Where can be?
Cerebral cortex.
Cerebral cortex. That's all right. Cerebral cortex. Yes. What's the physiology of this upgoing plantar? Children, what do you get? Newborns.
Yes, you will get upgoing plantar in children.
Okay. So why in adults it is not there?
Myelination will be absent in case of
Okay.
children.
So once myelination takes place, how it becomes flexor? How it becomes flexor? What is the effect of pyramidal system on plantar response?
There will be cortical inhibition.
Inhibition. That is taken off when there is a pyramidal lesion. Okay. Pyramidal lesion. Okay. Fine. Fine. Now, what is the root value of plantar response?
L5
Which is sensory, which is motor?
L5 is motor, S1 is sensory.
Sensory S1 is transmitted through, carried through which nerve?
Uh, su- Sural.
A tibial nerve, and goes to the
Tibial.
sciatic nerve. It goes to spinal cord S1, and the arc continues through L5, comes out through which nerve? Through
Blind.
through sciatic nerve, through peroneal nerve, and goes to which muscles? Which are the muscles to get
The
extensor plantar?
extensor hallucis
Longus and
longus uh, and tibialis anterior
extensor digitorum.
extensor digitorum.
Digitorum. So this is the root value L5S1, and you are expected to know root value and the nerve through which this is taking place. And where do you draw this plantar response?
Usually in the lateral aspect of the sole of the foot.
Which part? Which part? If you draw just
Uh,
below the
uh,
lateral malleolus, you call it Chaddock sign. It is not classical site.
Chaddock.
So classically, where do you
Yes.
draw?
Sole of the foot lateral up to the base of the
Alala. It is the junction between the plantar aspect and the lateral aspect. Okay. Junction between the dorsal aspect and the plantar aspect. That line you have to draw. Okay.
sir.
That line you have to draw. And so if you don't get it, go still further medially, like that you get. Okay.
Okay, sir.
So,
Okay, sir.
are there any other techniques of eliciting the reflex?
Chaddock sign, Gordon sign,
There are 12 signs. 12 signs elicited. Okay, if you know well and good. What is the basic principle behind it? The reflexogenic zone increases. When the complete corticospinal lesion, reflexogenic zone increases. Some people you get elicit plantar response when you go to the classical site. Some people may be still medially. So individual variations are also there. Okay. And what are the muscles contracting when you stimulate the plantar?
gastrocnemius,
Now before that, which muscle contracts?
uh,
Above the knees. Tensor fascia lata,
sensor fascia lata, yeah,
adductors, sartorius.
abductors,
Then only
pelvis.
comes the muscles of the foot. Okay. So you have got extensor plantar here. Yes. What else? That's all, eh?
Only that. Finding is only
Only that
current
much.
extensor
So
plantar.
any investigations given?
Investigations
Not given. Okay. So you said
not
this patient is dehydrated, and you said
sir.
this patient is having hyponatremia. So how will you know
Yes.
it is due to volume depletion producing hyponatremia or otherwise? How will you know? You said it is likely that it is thiazide-induced hyponatremia, and you said it is dehydration because of vomiting. So how will you know it is dehydration that is producing the problem?
Actually, if it is hypovolemic, you'll look for urine spot sodium. In thiazide
No,
induced hyponatremia,
clinical methods.
symptoms itself,
Symptoms of hypovolemia. How do you know? Somebody in the casualty, how do you know there's a volume loss?
dehydration,
How do you look for it? That I'm asking you. Skin
dehydration
turgor,
state
tongue,
or skin turgor,
tachycardia. What is more specific?
irritability, insensitivity,
What's more specific? Will you check the standing blood
skin
pressure?
turd. Yes, orthostatic.
Hypotension. So that's what you do ask for in this
In
case.
hypovolemia,
And what are the investigations you plan in this case?
you look for urine spot sodium,
No, you don't want serum sodium, eh?
serum sodium.
You
Look
want
for
serum sodium
sodium.
first. Serum sodium is in this is 106.
Sir,
106.
okay, sir.
So what's the diagnosis here?
severe hyponatremia.
Severe. When why do you
Uh,
say severe?
less than one. Less than 126 is
Less than
mild.
120. Less
One
than 120 is severe type of hyponatremia.
hyponatremia.
So, what is meant by acute hyponatremia? What is meant by chronic hyponatremia?
Acute hyponatremia within
48 hours. And what symptoms they have?
48 hours. Patient presents with vomiting,
Cerebral edema. What are
symptom
the
tiredness,
why they get cerebral edema?
cerebral edema secondary to osmal
What?
overcorrection.
No, no correction, no correction given. Before presentation, they cerebral edema. Why? Acute presentation.
Change in osmotic change occurs.
What osmotic change?
Shift of uh,
Who is shifting?
ions.
Which ion is shifting?
Sodium.
No, it is a sudden loss of sodium from the circulation. At same time, sodium is normally maintained in the brain. So what will happen to fluid?
The fluid will
Shift to
extracellular
fluid will shift to brain. It will produce brain edema. So they go for coning and they may die. So acute hyponatremia is not that good. Chronic insidious onset, and they come as our patient has. So what are the common symptoms with which they present?
patient usually presents with generalized
Headache,
tiredness,
headache,
altered sensorium,
headache.
headache, vomiting, seizures.
Not like that,
Uh,
not like that. If it is mild, you get only headache, vomiting, nausea as in this
Headache and
patient.
vomiting.
As it becomes severe, there will be some amount of altered in the sensation. It's not
Yes.
there here. No seizure,
No,
no coma.
no seizures
So,
also.
so that way it is not very bad, because if it's developing insidiously, sometime even if it's severe, you may not have comatose stage. Okay.
Sure.
So why do people get hyponatremia? What's the mechanism? Why do you get hyponatremia and congestive heart failure?
Because of dilutional hyponatremia due to hypervolemia.
Hypovolemia. So why they are having edema
Hyper,
then?
hypervolemia, sir.
So it is dilutional.
Yes.
Dilutional. Why do you get hyponatremia in cirrhosis liver?
Cirrhosis. Also maybe due to edema, hypervolemia,
O-
dilutional hyponatremia.
Okay, okay. So how do you classify this hyponatremia?
Can be hypovolemic or euvolemic.
So how will you know clinically which is what?
Hypovolemic usually by patient will be
Orthostatic
dehydrated.
hypotension. Euvolemia?
What for the hypertension is the
Euvolemia?
euvolemic.
No edema.
Clinically,
No
no edema,
JVP.
no
BP
signs
is
of
normal.
dehydration also.
Okay. And hypervolemia?
Hypervolemia, patient will be edematous.
Edematous.
Uh,
Okay.
yes.
You say edematous. Okay. So what will you do when somebody has got, and do they fall usually? Hyponatremia patients?
Fall.
Yes, they got important symptom is fall.
Yes.
Okay, instability,
Okay.
ataxia. Which are not there here, but the patient is not walking. That's the story here. So what is the next investigation you will do in this case? You will set urine sodium.
Or sodium.
Eh? You will do urine
Yes, sir.
sodium, or you will check for the osmolality. Is it true hyponatremia or is it pseudo hyponatremia? True hyponatremia, what will be osmolality like? How to calculate osmolality? What's formula, Dilruba?
Seven, um, 2 into sodium plus
So
potassium
2 and
minus
sodium is 212 here. Okay, then sodium into 2, then
so 2 into sodium plus potassium plus blood glucose plus blood urea nitrogen by 18.
no, not 18. Blood urine natrium divided by
by
2.8,
1 point
2.8, and glucose divided
1
by 18. What is the 18 business?
18.
How 18? How did you get this 18?
Weight of the uh,
Molecular weight. So what is
blood
the
urea
what is the chemical structure of glucose? Tell me. How much carbon? How much?
uh,
Ah. Tell.
C6H12O6.
Oh, 6. So it's based upon this formula you calculate the molecular weight. Accordingly you do. Okay. So
Yes.
normal osmolality is how much?
Um, 1 180
Why Dilruba? If you got 100 sodium, it will be 200. Usually sodium is above that, so how can be in hundreds? It has been 200s.
200
How much? Normal osmolality. 280, 295, not 30, 280, 295. So if it is a true hyponatremia, what do you expect? The sodium will be very low. So what do you expect? The osmolality will be low.
Yes, osmolality will be low.
Low. Suppose your glucose is very high. What do you expect osmolality be?
It will be high.
High. So when you give mannitol
Hypertension.
intravenously, severe hyperglycemia, you get another group of patients with hyponatremia. Okay, in whom osmolality is high. So you can rule out that condition. And then you have got a condition where you have got normal amount of osmolality. Okay, but
Yes, sir.
sodium is low. What are they? So
When glucose is high,
dyslipidemia and
dyslipidemia,
and
hyperglycemia.
hyperproteinemia producing conditions. What's the mechanism by which you get hyponatremia in this patient? Because the water is replaced by proteins and lipids in the blood. So 93% plasma water is replaced by it becomes lesser, and the protein content 7% becomes more. Okay, so when there is marked dyslipidemia and myeloma and all, you may get hyponatremia. So these things are taken into consideration. So three categories of hyponatremia based upon osmolality. Now it is true osmolality. How will you proceed further? It is a low osmolality, less than 280. So what will you do? So here you divide them into euvolemia, hypervolemia and hypovolemia. If it is hypervolemia, what will happen to the urine sodium?
Urine sodium will be less. Hyperolemia.
Volemia. Suppose it's a case of renal failure. What will
Yes.
be urine sodium like?
Sodium can be high if
High.
it is.
So hypervolemia have two types. With the low sodium
Yes,
in the
can
urine
be.
and more. Okay. Suppose it is hypovolemic. Hypovolemic.
Yes.
What will you do? Urine sodium.
Urine sodium will be normal or low.
So okay, you said this patient has got diuretic induced hyponatremia.
Hyponatremia.
So what do you expect in this urine sodium?
Urine sodium will be high in case of
High,
diuretic
but you said low.
induced.
Okay, so which situation you will find patient hypovolemia but sodium is less in the urine?
In diuretic induced
No,
hyponatremia.
no. You see, diuretic induced urine sodium is high. The urine is being lost through the urine, no? Sodium is going through urine, so how can be low? So which situation you will
And
find?
sir, hypovolemia and urine spot sodium high അല്ലേ sir ചോദിച്ചേ?
അത് diuretic കുറവാണെങ്കിലോ?
ഉം.
If urine sodium is low, less than 20,
Maybe extra renal losses.
gastrointestinal losses. Yes,
GI loss vomit.
third space. Well, that's possible. So you get third category, euvolemia, hyponatremia.
Yes.
Okay, so What will you do with urine sodium?
Urine spot sodium will be high, will be more than
If it is
20.
if it is SIDH, hypothyroidism or Addison's disease. True?
So,
Okay, if it is less, what will you suspect? Somebody is having less amount of urine sodium. So what is hysterical polydipsia? Hysterical
this is
polydipsia.
patient drinks
Eh?
increased fast.
Okay, so that is a situation where you
Psychotic
can have.
disorder.
What is beer protomania? Beer protomania. Somebody is drinking large amounts of beer. Same thing happens. So, so if this particular patient is possibly having drug-induced hyponatremia, you will.
Contraindication.
Okay, so I hand over to Stephen. Stephen, you take over. Are you here? Stephen, can you hear me?
Yeah, yes, sir.
Yeah, you take over.
Okay, sir.
Then Naveen, then Maridas. Any points to added?
Uh, in this patient, like SIADH, can you tell me some clinical findings?
Not clear.
In SIADH, what are the lab findings? How can you, when you suspect SIADH? Like what will be the uric acid? What will be the urea? What lab results
Urine
are
spot
you?
urine spot sodium will be more than 20. It is actually a diagnosis of exclusion. Uh, High. There will be decreased uric acid, hypouricemia, hypocalcemia.
What happened to uric acid levels?
Uric acid can be low in case of SIADH. Hello?
Okay. So can in this patient has vomiting. So can vomiting cause SIADH?
Usually, hypovolemic hyponatremia, usually vomiting. Because after,
Eh,
vomiting can be a manifestation of hyponatremia. Maybe after.
Vomiting can also cause the release of ADH. So in patients who have vomiting, you can also have similar. It might be similar to SIDH because during vomiting there is some amount of release of ADH.
Okay.
What is the correction for hyponatremia? How do you correct? Is there any limit?
Yes, usually 10 to 12 millisieverts per 24 hours. We cannot overcorrect more than
8 to 10, 24 within 24 hours, and 18, 48 hours.
okay.
Complication of overcorrection,
One is osmotic demyelination syndrome.
presentation of ODS,
Present, usually patient presents with quadriparesis, locked in state. Patient can present in locked in state with complete paralysis of both upper limb and lower limb.
how do you treat ODS?
Stop for
What?
correct with high uh, correct hypernatremia by giving half ns.
If it is rapid correction, you can try plasma exchange. Can be tried.
Plasma extension.
Exchange, yeah.
Okay. Mm.
Naveen, any more points to be added?
Sir. So what is your diagnosis? Hyponatremia, right?
Yes, sir.
Etiology?
Drug induced, thiazide induced
Okay.
hyponatremia.
Thiazide induced. So it's a diuretic induced hyponatremia or paucity.
Yes.
Out of the diuretics, what are the types of diuretics we generally use in the body? We have the loop diuretics
We
and
use
diacetyl diuretics.
diuretics, loop diuretics,
Yeah. Then MRA, intrahepatic
mineralocorticoid
anticonvulsant MRA. Okay,
antigens,
out of this, generally we use loop diuretics
loop
versus
diuretics and diuretics.
diacetyl. So, which type of diuretic is more prone to produce hyponatremia?
Thiazide diuretics. First is metolazone, then thiazide diuretics.
Okay. What about loop diuretics?
Loop diuretics more for hypokalemia than hyponatremia.
No, commonly does loop diuretics produce hyponatremia or not? Commonly നമ്മൾ
Yes.
കാണാറുണ്ടോ?
Uh,
Classics എടുത്തിട്ട് chronic, I mean, acute or chronic. Generally, does it produce or not?
yes, it produces.
If it doesn't produce, is there a reason why? Or in other words, why is thiazide producing more of hyponatremia compared to loop diuretics in clinical
Because
practice? Is there any specific reason?
thiazide is acting on the sodium
Yes,
uh,
very good.
that
Thiazide acts on.
channel and connecting that
അല്ല
till
എന്താണ്
sodium calcium exchanger.
Okay, which path? Sodium calcium ആണോ?
അല്ല sodium potassium 2 chloride.
So loop diuretic എവിടാ?
അല്ല അത് ലൂപ്പ് ഡയറക്റ്റ് അത് ലൂപ്പ് ഡയറക്റ്റ് സർ
So
സോഡിയം
basically,
ക്ലോറൈഡ്
where does the loop diuretic act? Is it in the medulla or cortex?
മെഡുല്ല
Mainly in the medulla.
യെസ്
Okay.
സർ
So generally, എന്താ സംഭവിക്കുന്നത് പറഞ്ഞു കഴിഞ്ഞാൽ for this ADH water reabsorption that takes place in the medulla. So when you give loop diuretics, ഈ പറഞ്ഞ medullary interstitial gradient is broken down. So loop diuretics എന്താ സംഭവിക്കുന്നത് പറഞ്ഞു കഴിഞ്ഞാൽ ADH cannot act. So the amount of water retention compared to thiazide diuretics is less. അപ്പോൾ അവിടെ ഒരു dilution component കുറവാണ് when you give a loop diuretic. So that is the reason why thiazides are supposed to produce more of hyponatremia than loop diuretics. മനസ്സിലായോ?
ഓക്കെ
Maridas, would like to add more points?
Yes, sir. What is cerebral salt wasting? Cerebral salt wasting, how do you differentiate it from SIADH? Will the patient be euvolemic or hypovolemic? In which condition patient will be hypovolemic? In which condition patient will be euvolemic? You see, when the patients know that they come with this headache as well as hyponatremia. Yeah, cerebral salt wasting, you get hypovolemia, and the other one, the patient will be euvolemic. Okay, so how will you treat? Which are few conditions which are associated with cerebral salt wasting?
brain post from like
Myomas,
surgery after surgery
meningitis,
and
encephalitis, pituitary, post-pituitary surgery.
endocarditis meningitis and all post surgery.
Yeah, and headache with hyponatremia, severe occipital headache. SAH.
Subarachnoid hemorrhage.
Okay.
Yes, yes.
Okay. And what is the difference in treatment? Where do you give saline? Where do you get normal saline?
In cerebral salt wasting,
Okay.
you give normal.
Okay. Okay. Thank you.
Anybody else in the group want to say something? Karthika or somebody wants to say something?
One more
Anybody
question.
else?
Complication you told locked-in syndrome പറഞ്ഞില്ലേ?
Yes, sir.
What is the difference between locked-in syndrome and Mann-Barrel syndrome? Same or difference ഉണ്ടോ?
Locked in syndrome and
Mann-Barrel syndrome.
no, sir, not clear.
Mann-Barrel syndrome.
For man direction.
Both are different, okay? Not the
Okay.
same. In 50 days, I used to think it is the same. The difference is locked-in syndrome, both upper limb plus lower limb is affected. Whereas in man in barrel, barrel അകത്തുള്ള ഒരാൾ വിചാരിച്ചാൽ മതി. But
ആ
കൈ എക്സ്റ്റെൻഡ് ചെയ്യാൻ പറ്റത്തില്ല. It's only by brachial paralysis. Only the arms are affected in man in barrel syndrome. Legs are normal. Okay.
ഓക്കെ ഓക്കെ സർ.
Any more comments by anybody? Needu? No. Anybody? Jisa? No. If not, can we go to the X-ray? You have got an X-ray with you? You have seen or not?
യെസ് സർ.
Yes. Naveen or Maridas, who is discussing X-ray? Yes. Maridas? You tell the findings X-ray, Kartika.
So this is a chest X-ray PA view showing bilateral miliary shadows in a patient who has a history of weight loss and lymphadenopathy and hyperosplenomegaly. So this might be an X-ray of miliary tuberculosis.
Maridas to ask questions.
Okay, what are the other differences?
Miliary shadows can be due to other infections as well.
Why do you say there is shadow?
Hello, sir.
Size.
Sir.
Size. What is the size?
Definition of miliary mottling. It has to be less than 2 millimeters. Miliary
2 millimeters.
millets.
2 millimeters. Okay. 2 to 3. Okay, 2 millimeters.
So what other condition you get fever with hepatosplenomegaly and miliary shadows?
Other histoplasmosis, pneumocystis jirovecii infection.
A pneumocystis doesn't produce miliary shadows. No.
Histoplasmosis is okay.
Histoplasmosis okay.
Legionella usually they present with pleural effusions.
Legionella pneumonia is a pneumonia, not a miliary shadow. If you take away hepatosplenomegaly and fever, you can get in hemocytosis. You can get in lymphangitis carcinomatosis. You may get in sarcoidosis, tropical eosinophilia. There are few conditions producing miliary shadowing. So with the history of fever and epidemiology, TB being very common here, you may consider TB as a possibility. Okay. So what is the MANDU status of this patient? MANDU testing in this patient? What will the report like?
Will it be falsely positive, falsely negative? Which one?
It will be just normal or highly reactive or just no reaction. What is happening?
It will be just positive.
It is usually negative. Miliary,
Negative, no? It is falsely
it
negative.
is negative. Negative MANDU is a feature of disseminated tuberculosis sometimes. So how will you treat this patient with the miliary tuberculosis?
We start the patient on anti-tubercular drugs.
Like?
Isoniazid, rifampicin, and thunderdon pyrazine.
Yes. After 3 days, patient went into shock. What is the possibility?
Isoniazid.
What reaction? Yeah, it produced shock.
What chemical?
Is it affecting only the lungs or any other organ?
Hypoglycemia,
Adrenaline sufficiency.
So why this patient went into shock when you started the treatment? 3 days after, not earlier. What's the reason?
iris.
What is the relationship between rifampicin and metabolism of cortisol? Rifampicin is a drug that precipitates adrenal crisis. Okay. Also remember that it's one of the situations where you are justified in giving corticosteroids because you presume that this patient is possibly having adrenal involvement also. Okay, let's go to the ECG now. Naveen, please take over.
sir. How is present in ECG? Kartika.
Sir, this is So this is an ECG showing a complete heart block.
Okay, take the long
Complete
lead.
heart.
Take the long lead.
Okay.
And what's happening to PR
First,
interval? What's happening to PR
Can
interval?
you tell it is complete
there
heart
is a
block?
PR prolongation. After the first P, there is a PR prolongation. Then the second P is not conducted. Then the next PR interval is shorter than the first one. So there is a variable PR interval, and there is no definite pattern for it, and some Ps are not conducted.
Is this regular rhythm or not? P rhythm, is it regular? QRS, is it regular?
P rhythm is not regular.
In complete heart block, what happened to P rhythm?
Just,
Is the QRS normal, regular?
um, yes, sir.
What
QRS is
about
regular.
QRS?
QRS
What
is
about the pulse? Pulse is it regular or irregular? Complete heart block.
regular.
Here, what is happened to QRS?
QRS is regular in this.
Regular or no? Naveen?
Sir. QRS regular, sir.
Regular or no? Is it a Wangeback phenomenon? From the ECG you sent to me, it's not very clear, but I thought it can be Wangeback phenomenon. Long lead, PR prolonged,
Yes.
server prolonged, there's a drop. Is it like that?
Uh, I feel sir more of like ഒരു QRS more of regular പിന്നെ ഒരു നോൺ കണ്ടക്റ്റഡ് കുറെ P waves ഉള്ളതുകൊണ്ട് I thought it was more of like a complete heart block.
Complete heart. Okay. So what's the width of this QRS complex?
Um, there are three small squares.
Normal or
Less
abnormal?
than 120.
Normal.
Normal. So where is the block?
A,
Complete heart block വന്നു കഴിഞ്ഞാൽ what is the significance of knowing the width of QRS complex?
size.
Which side?
Size of block.
Okay. Jisa to take over. Is she around?
Yes,
Yes. Then what do you say?
the QRS is narrow. The block will be after the AV node.
Or before? If there's a narrow QRS indicates a supra his, and wider indicates a infra his. So supra his has got a better prognosis, infra his has got a bad prognosis, which is more likely to be congenital.
Above
Above is likely to be congenital, below is likely to be acquired. So what are the causes of this acquired complete heart block?
acquired degenerative any pre-existing heart disease
Degenerative,
or
okay.
MI
What is the pre-existing heart disease you're talking about?
degenerative.
Any valvular lesion can predispose to complete heart block. Any drugs can predispose to it.
Any metabolic insufficiency, electrolyte imbalance that can lead to complete
Hypokalemia,
hypo,
hyperkalemia.
Okay. What are the drugs blocking the AV?
Drugs blocking, beta blockers, calcium channel blockers.
ABCD. Okay, adenosine beta blocker, calcium channel blocker, digoxin, or BCD commonly. So any of this in excess can block the AV node, can result in high degree AV block or complete heart block.
Can you get complete heart block in acute myocardial infarction?
Yes, sir.
How?
In inferior column,
So is it permanent or temporary? Can you hear me?
yes, sir.
Yes. So what is the prognosis outlook? Inferior wall MI usually temporary and patient may recover. What are the physical findings you expect in this patient? Needu.
examination, pulse may be regular
Hmm.
and bradycardia
May be regular
visible.
or may be irregular. Always regular or what? Is regular. Okay, right.
Yes.
Bradycardia expected or tachycardia expected?
Bradycardia.
Okay, then blood pressure.
Blood pressure
Pardon?
red, high, reduce.
Blood pressure is?
Re- Normal as cardiac output
Blood pressure may be
is
normal, it may be low. If it is hypotension, you require immediate temporary pacing. So hypotension may be there. It is not essential that it is always normal. Okay. It can be normal also. Okay. Then what else?
JVP,
JVP.
Canon, Canon AB will be there.
Cannon waves may be seen. What's a cannon wave?
When atria contracting against a closed
So what are other
ventricle.
situations you can have that?
Regular canon ആണ്
Gen-
irregular canon waves ആണ്.
in case of irregular Canon wave for complete heart block.
Yeah.
Regular, regular.
Regular ആണ്. What about the T waves? TP interval എങ്ങനെയായിരിക്കും?
PP interval
Or
will be
regular?
normal. RR interval will be same, and PR interval is varying. So irregular Canon.
Okay. ECG, what do you think? Where is the QRS complex arising from? So when you have a complete heart block, normally this P wave is not conducted down the AV node. So where is the rhythm originating from?
Above bundle
Is
of
it
his
from the ventricles? Is it from the ventricles or no?
above bundle of his is originating as QRS complex is narrow.
No, no. Is it originating from the ventricles? Yes or no? Ventricular rhythm ആണോ? Ventricular escape beats ആണോ? Complete heart block with ventricular escape beats ആണോ അല്ലേ?
No.
Look at the morphology QRS. If it is from the ventricle, what happens? Generally,
Broad
it's a
complex. Broad
broad
complex.
complex. That is one sign for identifying whether it is from the ventricle or not. What is the second? What is the normal ventricular rate?
No,
Fast
ventricular
ആയിരിക്കും,
rate
slow
is
ആയിരിക്കും?
slow ആയിരിക്കും.
Slow ആയിരിക്കും. Usually it will be less than 40, 20 to 40 ആണ്.
Yes.
Okay. And junction the normal rate എത്രയാണ്? If it is from the junction. Junction is 40 to 60.
40
Okay.
to
And that may present with a narrow or slightly wide QRS complex. So ഇവിടെ നോക്കിക്കഴിയുമ്പോഴത്തേക്കും what is the rate, ventricular rate you are getting?
32. 30 to 40 only.
Okay. With a narrow district.
Yeah.
So it could be probably junctional escape beats ആയിരിക്കും. 40 to 60. Complete heart block with the junctional escape beats.
Okay, sir. Okay,
Okay.
sir.
What is that phenomenon known as T and QRS? ഇതിന് ഡിസോസിയേഷൻ എന്ന് പറയുന്നത് AV ഡിസോസിയേഷൻ കേട്ടിട്ടുണ്ടോ?
കേട്ടിട്ടുണ്ട് സർ.
Where else you get AV dissociation?
ജംഗ്ഷണൽ rhythm.
ജംഗ്ഷൻ റൂപത്തില് ഞാൻ പറഞ്ഞ കംപ്ലീറ്റ് ഹാർട്ട് ബ്ലോക്കിൽ വരാറുണ്ട്. വരാം ഫാസ്റ്റ് ആയിട്ട് വരുന്നത്
Atrial fibrillation. VT.
VT also, but the thing in VT is sometimes these P waves might be transmitted down the QRS complex producing fusion beats and complex beats ഒക്കെ മനസ്സിലായോ? With a fast rate. So how do you manage this patient?
According to symptom, here's a patient presented with hypotension and
Symptom ഇല്ല.
palpitation and
Patient symptom ഇല്ലെങ്കിൽ ഇൻസിഡന്റലി ഡിറ്റക്ട് ചെയ്താന്ന് വിചാരിച്ചോ. Would you put a pacemaker or not?
yes,
for complete heart block,
Generally,
we
it is
have
very,
to.
very, very, very unlikely for a patient with complete heart block not to manifest with symptom. Even though asymptomatic anaglim, complete heart block or third degree heart block is an indication for symptoms.
Pacing.
So if this patient is having symptom, what symptom they will come with?
Syncope,
Any other?
palpitation.
No, palpitation is only for tachycardia, not for bradycardia. Only palpitation. Other symptom they will have? Only syncope? Can they have seizure?
Okay, sir.
Can have the involuntary movements? Tonic seizures? Yes
Okay,
or
sir.
no? What is Stokes Adam attacks?
Sudden onset loss of
Huh? That's called cardiac syncope. What is Stokes Adams attack?
syncopal attacks.
Singular attack, another term. It's a ventricular asystole characterized by loss of consciousness and possibly involuntary movements. So,
Okay,
what all
sir.
situations can put Stokes Adam?
Uh, type 2, Mobitz type
Type
2,
is
complete
type
heart block.
2. Type 2. Okay. So, this patient may come with loss of consciousness, may come with syncopal attacks, seizures. So, you may think about the causes. Name some poisons producing complete heart block.
Odolon.
Odolam is vegetable poisons. Okay. What about tricyclic antidepressants? Can it produce any arrhythmia, like complete heart block?
Bong.
Hmm?
Bong.
Yes, a complete heart block can be produced by drugs also. So,
Okay, sir.
complete heart block is an emergency. You have to recognize it. And myocardial infarction may be a potentially reversible type of complete heart block, so also drugs. In those cases, you give temporary pacemaking and stop. Okay.